And just to see where this is heading, so there is lots of work and lots of interesting things happening in this space, right? So if you take the visualization or visual data to the next step, now we are looking at how 3D printing can be used in medicine. One of the most exciting areas is surgery planning, where while in the earlier screen when we saw things like MRI that can be visualized on the screen, it's still a virtual image and it's still on a flat screen. A doctor would get a much better perception of the problem if they could hold the problem in their hand before they did surgery. Right? So the approach that 3D printing is taking is can we take the same MRI type data and actually print out a physical model, which the doctors can now play around with to say, what does the condition really look like? How should I approach surgery? What is the best direction of access? What are the other organs that might or might not get affected and so on. So this is now real. It's not anymore fiction. There are hospitals in India that are using this quite regularly. It is not very difficult technology. There is some technology to be done. But where it's become very helpful is in treating, I would say, somewhat abnormal conditions, especially with young children, where every case is almost different. The reason they come to the hospital is there is some particular abnormality that needs to be looked at, and it won't fit any standard textbook that you have. So rather than doctors starting the surgery and then trying to figure out what is really going on, they can do a lot of pre-work and hopefully reduce surgery time, improve the reduce the kind of cuts they have to make, improve chances of survival, success, and so on. So this is one end of where we are going. But again, healthcare data has been used in a long time to understand health conditions better, apart from individual data. So the other thing that's very important is to look at macro data, aggregate data, and say how can we get useful information out of it. And I thought use one of these as this is probably one of the classic examples. So is anyone familiar with this? The London cholera outbreak, and heard of? Yes, exactly. So the story, I mean, this happened 170 years back, right? So cholera at that time the causes of cholera were not known. In fact, it was strongly held that it was because of bad air or something like that. And there was lots of debates about it. In the 1850s, London had a serious outbreak of cholera. Thousands of people died. I don't unfortunately remember the exact number. The public health system was struggling with this, and basically people were just dying, and there was no idea of what was causing it, and therefore how this could be stopped. So along came this person, John Snow, who I think was an architect and a physician type of person, who said, let's analyze this data in a more systematic way. And what he did is he basically took a map of London, and on that marked all the locations of all the people who had died from cholera. Luckily, they had public record. They had to just go to every hospital, pick the thing, get their address, and start marking it down. And then he had this intuition that this was, or more than probably intuition, that this was not because of just bad air, it was because of contaminated water. So at that time, the source of water was hand pumps, public pumps. So what he did is he also mapped where the pumps were, the little circles you can see here and there, and he started seeing clusters of data. And so for example, that particular location was where there was the highest death, and if you look at it, he said that here's the pump and here are the people, and because it's a hand pump, that's where you have to go for water, you would go to the pump closest to you, logically, right? So all he had to do was kind of find clusters of people around pumps, and he found there was a very good correlation. He was able to show that the number of deaths were very high around certain pumps. So then he went and studied those pumps, tested the water in the pumps, and found that it had been contaminated by sewage essentially, because at that time they had only soak pits, as there was no sewage system in London at that time. So he was able to establish that contaminated water, contaminated by human waste, was the cause of cholera. And actually it took a long 20-30 years for this to get accepted, because partly probably the corporation didn't want to accept that this was a problem. And in fact, that pump is still standing there as a testament to that. And incidentally, the first action of the municipal corporation was to remove the handles of all the pumps that were contaminated. Right? There's something wrong in the water, let's not use it. But he persisted with that, was able to convince people about this, and it led to the formation of the sewage system in London itself. and it's completely changed urban planning. So this came from a methodical study of public data. So John Snow is known as the father of epidemiology. He started this whole field of how do we look at aggregate data and study epidemics and growth and spread of epidemics. So this is a great example of how data can be used and can help. And now it's done very standardly, whether you look at Zika virus or Ebola or any of these newer things. It's all about tracking down patients and what could be the possible transfer points. We also obviously now 150 years later, we have standard spatial analysis tools to do that. So the same thing could be done by, this clearly tells us where the concentrations are. This shows us where the increased concentrations and so on. And so now it is fairly standard for in epidemic analysis, epidemiology to take aggregate data and try to find patterns out of it visually. Right? So that's the. So these have all been different ways in which data has been used in healthcare, is being used in healthcare, I should say, from a macro level to an individual patient's level, down to very fine data about from MRIs or BP monitors. So now you have ambulatory devices, so you can get minute by minute data about your blood sugar or blood pressure or anything over days, and you can do very effective analysis and treatment. It's no longer just a random check or a symptomatic check. So this, given so much data, it's clearly a good candidate for looking at algorithms that can help us manage all this data. Data is there in many forms. It is becoming very difficult for an individual or small group to actually analyze all this data because of the variety and volume of data, and it seems to be amenable to machine learning type of algorithms. Or first of all, you start with image and signal processing for sure. How do I take ECG data and from that figure out the possible infractions that are happening? Now, so these kinds of algorithms are coming into play heavily in radiology, pathology. So looking at a slide under the microscope is really an image processing problem at some level. I mean, the brain does it very well, builds an intuition and experience and all that, but at the end of the day, it is finding patterns in a particular slide. So pathology, radiology type of things which are innately image processing oriented seem to be good candidates for image processing algorithms. And there's been tremendous progress in that. So you're familiar with IBM Watson as an example, which digests all the information that is fed to it about cancer research, cancer treatment, effectiveness of treatments and so on. And for a given patient is able to give you suggestions with probability, essentially saying this approach is the highest probable, this has 80% chance of success, this has 60% chance of success and so on. So it's able to give you very precise recommendations. At this point, they're still recommendations because even we don't have enough data to know if that is the right way of doing it. Google, yeah.
I have a question on IBM Watson. There's this famous use case they talk about. They said, if you have toothache, you're likely to get a heart attack within the next hour or so, whatever the nature is. Go to the nearest hospital. And then, so that was one case. Apparently, and then there was another case where the person had repeated something, coughing or some other symptoms, and IBM Watson said, "Don't worry about it. That guy actually got a heart attack." So, how do you?
Yeah. So these are very much incomplete that way, right?
So Mayo Clinic kind of suspended.
Yeah. Exactly. So. Yeah, so exactly. So I mean, they are not yet at the level of maturity where they can be they can replace the doctors. Nowhere that, right? They are still recommendation systems and or decision support systems. And for a near future, we should expect that doctors will still take the call. So, but at the same time, the benefits of this seem to be very good because they can see patterns in data which humans may not have the time to do. So many doctors are suggesting that this should be the way medicine is done, that you have access to a software algorithm, whatever, that is going to give you, that's going to help your decision making, and you take the call. So if you think about it, increasingly doctors, especially specialists, are going to spend less time with you because of the crush on the patient load that they have. They come out of a surgery, spend 2 minutes talking to the next patient, go back to the next surgery and so on. It is unrealistic to expect that they will make a completely objective, deterministic one, while a machine could point out errors, could point out. So as a support system, it's very valuable, and that's likely the way it will continue for some time. One of the big challenges is that it's a black box, right? So Google now has this, they're applying their DeepMind, AlphaGo type technology to pathology sample, and they claim that they can come up with the diagnosis better than most pathologists. Okay? But pathologists are not convinced because they want to understand what led to that determination. You talk to many doctors who are still very skeptical when they like the idea that it can help, but they want to know why, what, because especially the confirmation of diagnosis and the treatment plan depend a lot on what are the chain of reasoning that went there. Until our AI and ML systems can evolve to that, we are still, it is going to be a support system, but it's moving at a rapid pace. So we should expect realistically then in 5 years or less, Google's latest Alpha Chess thing shows that it doesn't take very long time to figure out these things if you can find the right problem to attack. So let's say roughly in a 5 to 10 year time frame, we should expect that algorithm-based decision support systems are going to be very important in the healthcare thing. For that, you need to have reliable data that's curated, tested, and accessible for these algorithms to work. And now we move from diagnosis to predictive systems, more on the lines of what you're saying. If a certain pattern of events have been detected, can that predict, say, the fact that this person will need to be taken to an ICU, or that this person can be discharged and will not need a readmission if they follow the protocol. Right? So we can use predictive systems to identify possible problems, but still in a very early stage. But this is again one of the promises that we are looking at, and it will come with uncertainty for some time. One of the big benefits that we can think about is, while we are talking about a lot of these in hospitals, in high-end clinics and so on, it has a potential big impact in public health, and I'll just use this now and then come back to it later. So one of the big challenges we have in public health is the sheer skewed ratio of doctors to patients. Right? The number of doctors, there's roughly one hospital per 100,000 people in India, roughly. And if they all have to come to the major, and these includes all kinds of hospitals. So if all the patients have to come to the major hospitals, just the processing of this is a huge load on the system. There are very few specialists. The pyramid is very sharp. And can we use technologies like this to improve the screening process? And there are lots of companies, startups especially, working in this space. For instance, can we do eye screening in the field, apply intelligent algorithms to it, and have only the critical or the important cases actually be referred up, and most can be treated in the field. So there are people doing this for eye, for inner ear, and various other kinds of diseases. It relies on the fact that we can capture data remotely using smartphones or some low-cost devices, do some computation on the data, typically images or other data, come up with a diagnosis or come up with a categorization, and decide that only this category of people actually need to see a specialist, and others can be treated in the field. If that is successfully done, it could have two big impacts. One is reduce the load on the specialists so they can treat the serious cases better, and more importantly, reduce the need for patients to make trips to the main hospitals, which is one of the biggest burdens on the system right now. So this has a big impact potentially in the public health system. So maybe that's a good way to say, so what is public health, or what are the issues in public health?
Insufficient resources.
Yeah, I'll come to the problems. There are lots of problems. Yeah. So basically, we are talking about the health services that the government runs to cater to, and it's open to anybody to. So in India, we have a very particular flavor of it. You can say the UK system is another kind of public health because the universal health coverage there and so on. So we'll focus on the India version of public health, which is primarily how do we have a hierarchy of medical facilities, starting with sub-centers, primary health centers, community health centers, taluka and district hospitals, urban hospitals, tertiary care hospitals, super specialties, and so on, all under the government health umbrella. The government funds these, manages programs in these, and tries to ensure the overall health of the population this way, improve health indicators of the population. A little bit of status check is probably important. If you look at the UN sustainable goals, health indicators are very important. And if you look at a couple of them, so the maternal mortality and the under 5 mortality, the infant mortality, India is not doing, I just blew up those. So we have a maternal mortality of 174 per 100,000 live births, and infant mortality of about 47 per 1,000. This number is about 2 years old. It's improved a little bit from there. It's far from where recommended standards are, or what the more advanced countries and some of the not so quote developed countries are in. So we are lagging behind by health indicators. We have large government programs running it, but the impact is still not there. There are studies that indicate that some improvement has happened in some areas, but a long way from the numbers we need to get. We probably need to look at how a mortality rate of close to 50, which I think it's about, in some places it's less, how can that come to 3 and 4 and things. That's the goal. So there's still a long way to go in terms of bringing these numbers to a more acceptable level. We should not be happy with these numbers, or should not accept that thing. There is the goals that have been set up for 2020, 2025, where these are supposed to be brought down significantly. And the Ministry of Health is tracking these and doing something. So if you take this as a macro problem, that in some sense, these are just 2 indicators, there are many more such indicators. So we have, there is an expectation that IT can help. Okay? And both the government and lots of other players are betting on it, spending a lot of time and money on this. And it is expected that with the proper use of IT, we can improve on many of these things, which will all contribute to the health indicators. Most fundamentally, the problem that we struggle with is access to healthcare, availability, affordability of healthcare, and quality healthcare. This has to do with numbers. The availability is very low because the patient doctor population is very poor. They're not necessarily easily to access, either for physical or other reasons. And you can always come to a city, but the cost is very high, so that is not a good answer. And even if you do get access, can you be sure about the quality of healthcare? So you can, obviously want to reduce health indicators, that's probably the most important thing, but you also want to improve the quality of life for people, at least in their interaction with healthcare. Can we reduce waiting times? Can we, right now, if they have to find access to medical care in a high-end hospital, the whole family typically travels to that place, spends a few days there, and it's a very painful and expensive process. So can we push more of this out into the places where the patients are? Can technology help there? We have to manage multiple things. So it is a reality that there is a severe shortage of physicians, even if the government cranks up and suddenly expands the number of super specialties. We are still a long way from it. Right now we produce single-digit numbers of specialists every year. Maybe 20 would be large. And we are talking about a population of 1.2 billion. So the scale is just huge. So we have to, so one of the promises of IT, which many health professionals say, is that help improve the reach of physicians. Can the same physician now address a much larger population through the use of appropriate technology? And this is where telemedicine is playing a potentially big role. And then how can we improve the efficiency of it? While a lot of money and effort is being spent, is it doing the right thing? Is it producing the results? So how do we track it? How do we monitor it, and so on? So this is the other place that IT is expected to help. And and all the challenges of India, of large geographic distances, different entities that are providing health service, and so on. So if you take stock of where we are, IT has been used in public health, but its impact has been minimal at this point. It is not really if you look at public health in terms of large numbers that are out there, there's very little IT actually being used. A lot of the earlier discussions we said are happening in private or urban hospitals, maybe some of the high-end government hospitals, but definitely not in the large. Right? So it's actually a problem. It's been going on for a while. People have been trying, but many of them have not got past the stage of pilots or local implementations. So typically, there are initiatives that will try to do some IT-based solution for one particular problem or issue or whatever, and that runs in one state for a while and doesn't sustain after that. So the government has been putting greater emphasis on this, And the National Health Mission, which has been around for 10 years or something, has put a lot of focus at least on gathering health data and putting programs in place for specific conditions. So there's an HMIS system that's used across many government healthcare programs, and so they track. And it's the first phase on many of these is to how do I monitor what's going on, how do I make sure things are happening, are enough people being, are enough visits happening, is enough vaccination happening, are pregnant women given the right sequence of booster shots, medications and so on. And the first phase of most of these has been just helping this, and traditionally these were done by just paper or Excel based reporting, and now that has slowly gone online. So now you have online health reporting systems, and to that extent they have been successful in the sense there is a structured way in which data is available and is available for policy and planning and other macro. If I look at these problems, you can abstract it away from healthcare and say these are known problems. IT is there. There are enough IT solutions to do that. Right? It has not worked. So while for many of these the solutions seem to be obvious, the initial attempts at the obvious solutions haven't worked, and they not worked because of some of the issues that we will discuss. Right? So, but at the same time, we have to live with the fact that there is a shortage of doctors. That's a separate problem to improve capacity. But if you do an analysis of numbers, you have to get 100x the times of doctors that you have. That's not feasible in any near time frame. So what we can look at is how can these systems make those doctors more effective at many different ways. Can they get better data so they can do their decisions better? Can they track what they're doing better? Can they get assistive systems that will help them? How can a MBBS doctor in the field get access to enough better decision making systems so that they can treat the patient better? So we can improve. One part of it is how do we improve the effectiveness of the doctors who are there. So the solution to this might be to look at public health programs as an example and do targeted intervention of IT, which is what is largely happening. Right? How do you take some part of the public health program and improve its functioning? And that will have some impact, some improvement. It is probably at this point it's still limited. And maybe we'll look at some of the challenges in a minute, right? So just to, on what is being done, there is now also an attempt to start capture. So the reporting systems are purely reporting, they're more like monitoring the program, but there's increasing effort to put patient data also in various centralized or decentralized databases. So NIC has this e-hospital system, which is now mandated at major central government hospitals, and they're starting to use it. Still using it in a very limited way, but in 5 to 10 years, maybe that will be better. Right? There are many issues with this, which touch on some other issues. For instance, how do you identify a patient? So a patient can go to any hospital in any state, any level of hospital. How do you identify a patient? Huh? No, a person walks in and says, I'm so and so. I want to now connect that to any other data about that patient that might already be in the database somewhere. So this is a challenge. Huh? Unique IDs. So what kind of unique IDs? Like Aadhaar, right? So we'll get back. That's what is happening. So the first concept that came in is at least at some level we'll have unique IDs. And you will use some mechanism to come up with a unique ID. Right? Now the next attempt that is being done right now is Aadhaar will be that unique ID. So hospital systems, especially in the government framework, are using that to identify the patient. That while that works, that obviously opens up other issues, especially when we talk about privacy of medical data. So today the ID is unique to a hospital. So the way hospitals used to do it historically was every visit was a new ID. Effectively, your duration of stay or encounter was an ID. Now at least it's for your repeat visits, you'll get back the same ID. So at least continuity of information within a hospital system is there. Correct. So that is the expectation, and that is a goal that has been set up. We have to see how long it takes for that to come. There are some practical issues with that, going back to privacy and confidentiality and security and things like that. So how do you share data in a way that will provide this? Because right now, because doctors are not sure about how the data will be used, they are restricting the data they put in.
Isn't that a practice in the UK and NHS?
Yes. In India, we have not evolved those both policies, practices, rules yet. There is a lot of discomfort among doctors to share data. There is comfort among hospitals to share. So it's
But it's been achieved in other universities.
not in the, even there are restrictions on what kind of data can be accessed. Yes. So that's where it's going. So the idea of this unique ID is to get there. Okay. It'll probably take a couple of iterations to get there. But clearly we need to enable continuity of care, and for that there is no way around it. There has to be a way to get data from anywhere and make it all integrated. The government system, so there are different challenges. There you have different hospitals, so some are run by the central government, some are run by the state government. Health is the administration of health is a state subject, so each state has its own way of doing things. There is no, each program is a vertical silo that cuts across things, so each of them has their own way of doing it. So there's not been enough attempt to integrate this. I'm happy if my program can do better, I'll worry about integration later, has been the common thing. So now that's beginning to change, but we have to look at it. So the use cases in a public health are even more challenging than what we might have thought in terms of continuity of care. And classic example that's used to test out any solution that comes up is migrant workers as an example. By definition, they are mobile, they're moving around, they can move anywhere. So while the government has a very good program for maternal care, the mother and child programs and all that, it still breaks down somewhat across state and other boundaries. So this unique ID is an attempt to fix that, but it's still not fully there. So the classic example that we should think about as use case to solve these is, imagine a migrant construction worker, a woman who is pregnant, she's a construction worker and she's pregnant, so she goes to the local PHC and starts a treatment. And the government has, and the program has very decent checks, diagnosis and recommendations that go on. Almost certainly she will go back to her hometown for the actual delivery, and that could be in a different state. And at that point, if that particular piece of paper that she's carrying doesn't get properly identified in another state, effectively that history is lost. So in some sense, the doctor starts all over again. The history is the oral history that this patient may be able to translate, may be able to articulate, and then that gets captured. Treatment happens, and then let's say the child is born and the child is reasonably healthy and so on. At some point, she'll move back to some other place probably. Right? So she's constantly moving, and it's so critical that, and we're talking about infant mortality for up to 5 years. So at least for 5 to 6 years, this information has to be tracked. And she's definitely going to have many different touch points in that thing. And right now, there is no system that consistently will be able to handle all this information. While the architectural framework and theory are there, in practice, it's not yet evolved. So these are practical problems that still need to be addressed. So why is this not happening? Since we know all the solutions and we technologists believe that these are, many people we talk to, or including I myself, so these are easy things to do, it's done. Why are we struggling? So what might be some of the reasons why it's not got any better than this?
Regulatory uncertainty.
There's no regulation at school, right? You do what you want.
Too many stakeholders.
Too many stakeholders, yes.
Reluctance of people to share data.
Reluctance of people, yeah.
Who will pay for all this?
Government, what's the problem? Money is not the issue.
Lack of
Lack of?
resources,
What kind of resources?
technology.
Technology. In India? You're supposed to be an IT superpower, right?
But still, like when compared to Western countries,
No, that I think lack of, okay. Yeah, you're right. Lack of the appropriate set of resources where it's actually an interdisciplinary thing. You have to have doctors, technologists all sit together and frame something, and it's not happening enough.
lack of resources, for example, when flu shot is administered for all the citizens, that is it's not a problem. But then government cannot do because lack of resources.
It's lack of priority, I would say, not lack of resources. If flu was identified as a priority program, it would have got the attention. It's not right now. There are much more serious disease burdens to deal with.